My name is Beth Leung, and I am an infectious diseases clinical pharmacy specialist at Unity Health Toronto in Toronto, Ontario, Canada. In this presentation, I will be providing a brief overview of pertinent drug information for Anakinra for SARS-CoV-2 infection. Anakinra is a recombinant non-glycosylated version of the human interleukin-1 receptor antagonist. It is identical to the natural non-glycosylated form of human IL-1 receptor antagonist protein, except for the addition of a single methionine residue at the N-terminus. It consists of 153 amino acids and has a molecular weight of 17.3 kilodaltons. Anakinra reaches maximum plasma concentrations 3 to 7 hours after subcutaneous injection, and its half-life is approximately 4 to 6 hours. Anakinra blocks the biological activity of both IL-1 alpha and beta by competitively inhibiting these interleukins from binding to the interleukin-1 type 1 receptor. Although the drug binds to the interleukin-1 receptor, it does not associate with IL-1 receptor accessory protein, meaning that it has no agonist activity on the receptor and therefore does not initiate signaling events. The IL-1 receptor is expressed in a variety of tissues and organs, as you can see in this diagram of interactions between IL-1 and various organ systems. Therefore, IL-1 is an important pro-inflammatory cytokine that mediates many cellular responses throughout the body. IL-1 was first described more than 35 years ago as a product secreted by monocytes and neutrophils. Typically, the term IL-1 refers to both IL-1 alpha and IL-1 beta, which are two key cytokines involved in the activation of innate immunity. Although IL-1 alpha and beta were some of the first proteins to be identified as important factors in leukocyte signaling, the IL-1 family actually has a total of 11 members now, including the two activating cytokines previously discussed, alpha and beta, as well as an inhibitory mediator, which is known as the IL-1 receptor antagonist. We also now know that once IL-1 alpha and 1 beta are activated, with the inflammasome playing an important role in activation, they act as potent pro-inflammatory cytokines with a broad range of activities that are involved in mediating cellular responses. IL-1 can lead to increased production of other cytokines such as TNF-alpha by T cells, as well as increased production of nitric oxide, prostaglandin, adhesion molecules by vascular endothelium, and release of histamine and thromboxane. This pro-inflammatory activity increases vasodilation and also signaling of monocytes and neutrophils to sites of tissue damage or stress. In fact, uncontrolled IL-1 activation has been described to play a central role in inflammatory diseases, including rare hereditary syndromes caused by mutations in inflammasome-associated genes, or more common diseases where neutrophil infiltration and IL-1 activation are present. In the case of rheumatoid arthritis and gout, IL-1 is involved in synovial inflammation and subsequent joint destruction, as these cytokines mediate tissue damage by altering cartilage and bone homeostasis. IL-1 is also thought to play an important role in inflammatory atherogenesis. Finally, IL-1 cytokines also foster the hypothalamic fever response and promote hyperalgesia. The overall role of the inflammatory response is still being explored as it relates to the current pandemic coronavirus, including similarities and differences between the pathophysiology and clinical features of COVID-19 infection and prior beta coronavirus infections. For example, increased serum levels of pro-inflammatory cytokines such as IL-1 beta were associated with pulmonary inflammation and lung damage with the initial SARS virus. Increased cytokine levels have also been described in MERS patients. Preliminary data from a Chinese cohort's experience with SARS-CoV-2 infected patients reported high levels of IL-1 beta and interferon gamma, and they also reported that patients with SARS-CoV-2 who required ICU admission had higher pro-inflammatory cytokine levels than those that did not require ICU admission. These reports are the basis from which the postulated role of cytokine storm as it relates to disease severity of SARS-CoV-2 were made. However, many questions remain, as the same initial Chinese data from Jinyantan Hospital in Wuhan that described cytokine storm linked to severity of illness also found that in SARS-CoV-2 infection, there was evidence of increased secretion of T helper 2 cytokines, which actually suppressed inflammation. This differs from data described with the initial SARS virus. Some critics have also pointed out that although high cytokine levels have been described in subsets of COVID-19 patients, these levels may not be quite as high as cytokine storm levels seen with other disease states. Anakinra was initially approved by the FDA in 2001 and by Health Canada in 2002 for treatment of rheumatoid arthritis, specifically in reducing signs and symptoms and slowing the progression of structural damage in adult patients with moderate to severe active RA who had failed one or more disease-modifying antirheumatic drugs. This medication later also received approved labeling for cryopyrin-associated periodic syndromes, specifically for treatment of neonatal onset multisystem inflammatory disease, or NOMID. As mentioned earlier, these are disease states in which the role of IL-1 has been more well described, and where clinical effect of IL-1 blockade has been clinically demonstrated in trials, and not just postulated based on mechanism of action. The approved dosing regimens for these indications are listed on this slide, as well as some of the off-label uses that have been reported in the literature, including familial Mediterranean fever, gout, and pericarditis. The dosing for off-label indications varies in duration, from a single dose to 3 days in gout to up to 6 months for pericarditis. Although the dosing for NOMID is a maximum of 8 milligrams per kilogram per day, the manufacturer notes very limited data with dosing greater than 5 milligrams per kilogram per day. As the drug has now been marketed for some time, previous data in labeled indications does give us some limited information about dosing in special populations. Studies in non-RA patients with varying degrees of renal insufficiency show that Anakinra is substantially excreted by the kidneys. In patients with severe or end-stage renal disease, creatinine clearance less than 30 mL per minute, the mean plasma clearance of Anakinra is decreased up to 75%. The manufacturer recommends careful evaluation of patients with renal impairment prior to initiating therapy and a changing dosing schedule, so considering administering the prescribed dose every other day if the patient has end-stage renal disease. Of note, due to its high molecular weight, Anakinra is not removed well by dialysis. The drug has not been studied well in hepatic impairment, and there is limited pediatric data available to draw on, although dosing is weight-based in the NOMID indication, for which it has an orphan drug status. Information related to the use of Anakinra during pregnancy is also limited. Guidance in RA patients suggests that although Anakinra should ideally be discontinued prior to conception due to unknown risk to the fetus, it may be continued carefully if no other treatment options are available. It is not known if Anakinra is present in breast milk, but endogenous IL-1 receptor antagonists can be found in breast milk. And although small case series data suggests no adverse effects have been observed in breastfeeding infants following maternal use of Anakinra, the manufacturer still recommends to avoid breastfeeding if possible due to the limited data. No specific dose adjustment has been recommended in the geriatric population. As mentioned earlier, it has been suggested that cytokine storm contributes to a variety of disease states due to the mechanistic role of cytokines in promoting inflammation. As it relates to Anakinra, one of the first suggestions citing potential benefit of Anakinra in SARS-CoV-2 infection comes from a correspondence published in The Lancet in mid-March, in which the authors outlined the potential benefit of immunosuppression therapies to treat viral-related hyperinflammation syndromes. The authors cite a reanalysis of a de-identified data obtained from early pre-approval trials of Anakinra in sepsis. Let's quickly review the historical data. An initial phase 1 trial of Anakinra in 1992, almost 30 years ago, gave single doses in healthy subjects, with 4 subjects receiving a dose as high as 10 milligrams per kilogram, given as an IV infusion over 3 hours, and monitored for 72 hours afterwards. Then, a phase 2 open-label, placebo-controlled trial demonstrated dose-related efficacy in sepsis and septic shock, particularly in patients with higher IL-1 levels at study entry. The most common source of infection at 30% was deemed respiratory, and the causative pathogen was bacterial in approximately 80% of cases and unknown in about 20%. Doses of Anakinra in the phase 2 trial went up to 133 milligrams per kilogram for 72 hours, and the study did not note a significant difference between Anakinra and placebo arms in frequency of adverse events, but specifics of adverse events were not described. The same group completed a phase 3 randomized double-blind trial comparing 1 or 2 milligrams per kilogram per hour of Anakinra versus placebo in patients with sepsis. In this trial, Anakinra did not meet the primary endpoint, which was improved 28-day survival. But in a non-a priori analysis, the investigators found that Anakinra did improve survival in patients with predicted mortality risk of 24%, with or without multi-organ dysfunction. The sources of infection were similar to the phase 2 trial, but there were less patients categories with an unknown pathogen, only 3 to 4%. There were also no significant differences in serious adverse events in the placebo versus Anakinra arms, but the adverse event rate was high at about 39%. Due to these results, a confirmatory phase 3 trial was performed in 1997, which enrolled patients with severe sepsis or septic shock. Dosing in this trial was similar to the prior phase 3, except for with the omission of the 1 milligram per kilogram per hour infusion option. Nonetheless, the study ended up being discontinued after the interim analysis, which found it unlikely to meet the primary efficacy endpoint, which was also 28-day all-cause mortality. The manufacturer notes that in these trials, even with the high dosing used, no serious acute toxicities attributable to the drug were identified. but the adverse event rate was quite high, with greater than 90% in both groups with severe sepsis. Although the sepsis trials were inconclusive, subsequent case reports describe Anakinra alone or in combination as effective in treating macrophage activation syndrome, also known as secondary HLH. MAS has a high mortality rate, up to 60%, as it is often associated with hemophagocytosis, coagulopathies, and severe liver dysfunction. It often presents with fulminant cytokine storm leading to fatal multi-organ dysfunction and can occur as a complication of infection, malignancy, or autoimmune disorders. Given the clinical and cytokine similarities between MAS and severe sepsis, a hypothesis is that septic patients with features of MAS may respond best to Anakinra. So in 2016, a group including some of the original investigators from the sepsis trials identified patients from the original phase 3 population with features suggestive of MAS, defined as hepatobiliary dysfunction and disseminated intravascular coagulation. When they reanalyzed the data, they found that the subset of MAS patients who received Anakinra had significantly lower mortality, 34.6%, than the subset of MAS patients who received placebo at 64.7%. This corresponded to a 47% decrease for the Anakinra group. This evaluation raised the possibility that a subset of septic patients with MAS syndromes may be more responsive to IL-1 blockade therapies. Anakinra carries boxed warnings in both the FDA and Health Canada monographs. Similar to tocilizumab, another immunomodulatory agent being studied in COVID-19, the boxed warning recommends to avoid Anakinra in patients with active infections due to increased incidence of serious infections. And of course, COVID-19 does classify as an active infection, so risk and benefit should be discussed on a case-by-case basis. The boxed warning also includes risk of hypersensitivity reaction, including anaphylaxis and angioedema. If severe allergic reaction occurs, it is recommended to discontinue further doses and treat the reaction appropriately. Of note, Anakinra is produced by recombinant DNA technology using an E. coli bacterial expression system, so patients with hypersensitivity to these proteins should not use the drug. Patients receiving Anakinra in RA clinical trials had a higher than expected incidence of lymphomas. However, Anakinra is also being studied for potential protective role against cancer progression, as dysregulation of the IL-1 pro-inflammatory cascade likely plays a role in initiation, progression, and invasiveness of certain malignancies. Currently, there is an unknown risk of IL-1 blockade on malignancy development. Common adverse effects observed in RA trials with Anakinra exposures of 6 to 12 months include injection site reactions, headache, vomiting, arthralgia, pyrexia, and nasopharyngitis. All occurred with an incidence above 10%, with similar frequencies in the placebo arms, but up to 70% in the case of injection site reactions. Serious infections occurred in 1.7% of RA patients receiving Anakinra and were mainly bacterial infections involving cellulitis, lung, or bone and joint. As mentioned earlier, Anakinra does carry a black box warning for risk of infection. A subset of RA patients with asthma had a higher incidence of serious infections with Anakinra at 4.5%, compared to no infections in the placebo arm. Therefore, it's recommended to be cautious in patients with underlying airway inflammation, and ideally these patients should be controlled with appropriate asthma therapies before initiating Anakinra. Post-marketing data suggests that infections of all organ systems and potential pathogens have been seen, and caution is recommended when considering Anakinra therapy for patients with recurrent infections or underlying conditions predisposing them to infections. Other notable adverse effects from clinical trials included neutropenia and transient liver enzyme elevations with reports of non-infectious hepatitis. Finally, few patients have been studied in the NOMID indication, but it was noted that one patient in the pivotal NOMID study experienced macrophage activation syndrome, or MAS. However, they had also experienced MAS prior to starting the study drug. Therefore, a causal relationship between Anakinra and MAS has not been established, and as mentioned earlier, Anakinra is postulated to actually have potential benefit in MAS. There were no permanent discontinuations of Anakinra treatment due to adverse reactions in the NOMID studies. Both pharmacokinetic and pharmacodynamic interactions should be reviewed for Anakinra. Firstly, additive immunosuppression may occur. Anakinra has been studied in combination with selected disease-modifying agents, such as methotrexate, and no significant signals of infection were seen in the RA clinical trials. But there are reports of higher incidence of infection risk when Anakinra is added to TNF-alpha agents, so the clinician must weigh risks and benefits of concomitant immunosuppressive therapies. Regarding cytochrome P450 enzyme activity, which is suppressed by increased IL-1 levels, enzyme function may be restored or enhanced when adding anakinra. CYP450 substrates with a narrow therapeutic index should be monitored closely upon initiation and discontinuation of anakinra therapy, and may require therapeutic drug monitoring, closer monitoring of drug effects, or dose adjustments. Finally, caution must be taken if vaccinations are to be administered, as immunomodulation may increase the risk of live vaccines, which are recommended to be avoided, and immunomodulation may decrease the efficacy of inactivated vaccine products. At the time of this update, limited clinical data exists to support the use of anakinra in the treatment of COVID-19. Still, with the pace at which COVID publications are coming out, a systematic review and meta-analysis has already been published using the limited data to date. This systematic review also included a variety of other anti-rheumatic medications which are being studied against COVID-19, but I mainly want to show you the summary table from their paper to highlight the lack of data and need for continued controlled trials. This analysis included 2 cohort studies and 1 case series. The 2 cohort studies evaluated mortality, so they were pooled in a quantitative analysis to a total of 141 patients, 91 of which received anakinra. Although they did find that anakinra was associated with a significantly lower risk of mortality, a pooled hazard ratio of 0.2 with a confidence interval of 0.1 to 0.4, compared to the standard of care, they cautioned that the studies included had significant limitations, including the Cavalli study with a high risk of bias and the Hewitt study with potential confounding, and that more well-designed trials are required for anakinra in the treatment of COVID-19. I will just briefly review the 2 cohort studies included in the systematic review. The first cohort study, published in early May, described a single-center retrospective cohort of a total of 29 patients on non-invasive ventilation who had signs of hyperinflammation, classified by CRP, ferritin, or both, and received high-dose IV anakinra, and 7 patients who received low-dose sub-Q anakinra. A control group of 16 patients did not receive any anakinra. It is important to note that standard treatments in March 2020, when the study was conducted, are no longer recommended. The high-dose anakinra was given until sustained clinical benefit, which is defined as 75% reduction in CRP and respiratory improvement classified by PaO2-FiO2 ratio of greater than 200 for at least 2 days, was obtained. In this case, high dose was stopped and 3 days of low dose sub-Q anakinra was given to avoid possible inflammatory relapse. High dose anakinra was also given until death, bacteremia, or side effects occurred, in which case no taper was given. At 21 days, investigators noted that 21 of 29 patients, so 72% of the high-dose group, had reduced CRP and improved respiratory function, while 50% of the standard group met these outcomes. 21-day survival was 90% in the high-dose anakinra group and 56% in the standard treatment group, while mechanical vent-free survival was noted at 72% and 50% respectively. The investigators did note that those who received low-dose anakinra did not seem to have any significant decrease in their CRP, or what they considered as a meaningful clinical effect, at 7 days, and thus they decided to stop low-dose anakinra without a taper. It was noted that no patients from the low-dose group or the control group moved to the high-dose cohort, but it was also unclear how investigators decided to use high versus low-dose anakinra in their cohort of patients, although it appeared that patients in the high-dose group had lower PaO2-FiO2 ratios and were classified as severe ARDS, compared to the low-dose anakinra group, who mainly had only moderate ARDS by definition. Patients in both the standard and anakinra arms were observed to have increased LFTs and bacteremia, but as the study had a low number of enrolled patients overall, it's hard to make any direct conclusions from these results. At the time of this update, the most recent published clinical trial data on anakinra and COVID-19 is from July, a retrospective manufacturer-sponsored cohort study of 96 patients from Paris, with 52 consecutive patients receiving anakinra for a total of 10 days, and 44 patients consisting of a historical control group meeting the same inclusion and exclusion criteria as the anakinra group, and these criteria are shown on the slide. Notably, none of the patients had invasive or non-invasive ventilation at baseline, and both groups received the standard of care during the data collection period, which included, again, a number of interventions that have since been shown to not be helpful or even be harmful. Investigators reported that the anakinra group seemed to have reduced need for mechanical ventilation and reduced mortality without serious side effects, but also encouraged more controlled trials to confirm their findings. So finally, I want to briefly review what trials are in progress aiming to study anakinra as a therapeutic for COVID-19 patients. From just 5 ongoing trials a few short months ago, there are now a number of additional trials registered. I won't go into each trial individually here, but you can always pause now or look at the slide deck PDF later for the details. I split these into currently recruiting and those not yet recruiting. One thing that hasn't changed is the same overall trend with the initial trials, in that there's still considerable variability in study designs, Anakinra regimens such as dosing and route, duration of therapy, goal enrollment, comparator arms, and also primary outcomes. You will also see that most of these studies are based in Europe, with just a few enrolling in North America, including REMAP-CAP, a multifactorial adaptive platform trial for community-acquired pneumonia. REMAP-CAP was already enrolling patients with severe CAP in its original study arms, such as antibiotic choice and corticosteroid use, well before this pandemic began. So they were well positioned to add an additional arm to study therapeutics for COVID-19, including an antiviral arm and an immune modulation arm, which includes Anakinra. The manufacturer sponsors study on this slide and the University of Alabama at Birmingham study listed on the next slide are the other main North American trials that are registering. Here are studies not currently recruiting or enrolling patients. You will note that the Anakinra arm of the Coromune study from France is listed as not enrolling yet, but of note, the tocilizumab arm of this trial has reported preliminary positive findings in April, although these have not yet been published in peer-reviewed literature. Finally, clinical pearls to consider for Anakinra are similar to those of other immunomodulators of interest in COVID-19, including tocilizumab. Although Anakinra is not quite as costly, it is still unclear how to identify patients who may benefit from immunomodulatory therapy, regardless of issues of variable drug availability and preserving supply for patients who are already on Anakinra for a labeled indication. It also remains to be seen how biomarker-guided therapies can impact clinical outcomes of COVID-19 patients. Of note, in July, a task force of the American College of Rheumatology released a clinical guidance document for multisystem inflammatory syndrome in children associated with hyperinflammation in COVID-19, in which Anakinra is suggested as a recommended treatment for pediatric patients who are refractory to IVIG and/or glucocorticoids, based mainly on the historical use of Anakinra in other pediatric hyperinflammatory syndromes and the relative safety profile. Clinicians must also assess secondary infection risks and drug interactions. As outlined earlier, dosing regimens are highly variable, so lacking clinical trials data, it's unclear what the appropriate dose for COVID-19 should be, including if it should be tapered or extended based on clinical response or specific biomarkers, and if there is an optimal timing dosing window in which the critically ill patient should receive Anakinra. Of note, Anakinra is only available as a prefilled syringe meant for sub-Q injection, although it does contain a citrate buffer and can be given intravenously according to the manufacturer. As sub-Q administration may not be desired in a critically ill patient, how to give IV Anakinra is also a challenge, as it is known to be light sensitive and very limited data is available regarding dilution, stability, or compatibility of IV infusions. Very limited data from a study of continuous infusion Anakinra and MAS suggests to use the compounded infusion as soon as possible from admixture, and not to use an overly concentrated or small volumes for continuous infusions, for concern of significant drug being stuck in the tubing line. In summary, Anakinra is a recombinant human IL-1 receptor antagonist. It is currently approved to treat rheumatoid arthritis and NOMID. Since cytokine storm and MAS may be involved in the pathogenesis of SARS-CoV-2 infection, Anakinra is under investigation for this indication. It has been studied in sepsis, and limited clinical data is available in SARS-CoV-2 infection. Safety profile is similar to other immunomodulatory therapies under consideration for SARS-CoV-2 infection, and currently the role of targeted immunomodulatory therapies for treatment of SARS-CoV-2 infection is not well defined. Thank you for viewing the Anakinra portion of the SIDP COVID-19 educational modules. Please feel free to contact me if you have any questions regarding the content covered in this presentation.